Hi, my name is Lucas Freund, and this is my presentation on Parkinson's disease. Parkinson's has physical, cognitive, and psychological symptoms. Physical symptoms can be broken down into motor and gastrointestinal symptoms. Motor symptoms are the most easily recognized of Parkinson's. Tremor, bradykinesia or slow movement, rigidity, and postural instability are core symptoms, and are referred to collectively as Parkinsonism. Difficulty with gait and balance are also extremely common. Symptoms begin on one side, typically in a hand, and spread as the disease progresses. Gastrointestinal symptoms include constipation, gastric dysmotility, or slow emptying of the stomach, and excessive production of saliva. The image on the right is a drawing from the 1800s showing the typical gait and posture of those with Parkinson's. Cognitive symptoms of Parkinson's include executive dysfunction, slowed cognitive processing speed, impaired recall, impaired perception of time, loss of smell, and difficulty sleeping. Psychological symptoms can vary significantly among those with Parkinson's, but psychosis, dementia, depression, anxiety, apathy, and anhedonia are all common. Impulse control disorders frequently result from treatment with dopamine replacement therapy. All symptoms worsen as the disease progresses. Physical symptoms appear first. Tremor is typically the first symptom, though may be preceded by gastrointestinal symptoms. This graphic excellently summarizes the prevalences and characteristics of the common psychological issues with Parkinson's. Apathy and anhedonia tend to occur early on with prevalence of up to 40% and may indicate a more severe disease course. Anxiety with up to 60% prevalence, depression with 35% prevalence, and psychosis with roughly 40% prevalence may occur sporadically at any point in disease progression. Dementia is extremely common in the later stages of Parkinson's with prevalence of over 80%. Impulse control disorders become more likely as the duration increases of dopamine replacement therapy with levodopa or dopamine agonists, and prevalence goes up to 60%. Parkinson's diagnosis is made based on motor symptoms and elimination of other disorders which cause Parkinsonism. Similar to Alzheimer's, diagnosis can only be fully confirmed via autopsy after death. Overall, accuracy of diagnoses is roughly 80%, with variance based on expertise of practitioner and the set of diagnostic criteria used. CT, MRI, and PET scans can provide indication of Parkinson's and/or eliminate some sources of secondary Parkinsonism. On the right is an image from an MRI scan of a patient with Parkinson's, showing both a normal swallowtail sign on one side of the substantia nigra and its absence on the other, which is indicative of Parkinson's. The criteria from the UK Queen Square Brain Bank for neurological disorders is one of the most commonly used and most accurate sets of diagnostic criteria. Diagnosis is made based on the presence of bradykinesia, at least one of muscular rigidity, 4 to 6 Hz tremor, or postural instability. The elimination of all exclusion criteria, which could indicate secondary Parkinsonism or a Parkinson plus disorder, such as a history of strokes or early dementia, as well as at least 3 of the following: unilateral onset, rest tremor, disease progressing over time, persistent asymmetry, excellent response to levodopa, levodopa-induced chorea, responding to levodopa for at least 5 years, or disease lasting for at least 10 years. Computed tomography shows no indication of Parkinson's, but can rule out many conditions such as encephalitis or some tumors that can cause secondary Parkinsonism. Magnetic resonance imaging can be used to rule out secondary Parkinsonism as well, but also shows some structures indicative of Parkinson's, such as the loss of the swallowtail sign on the substantia nigra. Positron emission topography and single photon emission computed tomography can be used to visualize glucose metabolism or activity of dopamine transporters in the basal ganglia. Below metabolism or activity is nonspecific to Parkinson's. The images below show some comparisons between PET and SPECT scans, normal patients and those with Parkinson's. In particular, the first two comparisons show a striking reduction in the activity of dopamine transporters in the Parkinson's patient. Parkinson's affects roughly 6 million people globally. Annual prevalence is roughly 0.3% in developed countries. Lifetime prevalence increases with age, up to 1% by age 60 and 4% by age 80. Prevalence in males is roughly 50% higher than in females. Incidence is 8 to 18 cases per 100,000 person years. Parkinson's is the second most common neurodegenerative disorder and the fastest growing as of 2021. Motor issues can make moving very difficult, even around the house, and many jobs can become impossible. Many with Parkinson's will avoid activities due to fear of falling, even those who have not fallen before. Many forms of communication can become difficult as motor issues progress, including speech, writing, body language, and facial expressions. Speech difficulties can be further compounded by cognitive issues. It's going to get harder to think through what you're going to say as quickly as you would like to say it. Becoming increasingly housebound can greatly restrict the social life of people with Parkinson's. Motor issues alone can become debilitating as Parkinson's progresses, and the isolation it can cause, alongside no longer being able to support oneself or do the things that they would enjoy, can contribute to or exacerbate the psychological symptoms associated with Parkinson's, such as depression. Parkinson's is caused by the death of neurons in the brain, with motor symptoms caused by the death of dopaminergic neurons in the substantia nigra. Surviving neurons tend to possess Lewy bodies, composed of alpha-synuclein. It's unknown if Lewy bodies are responsible for cell death or protective against it, with other forms of alpha-synuclein responsible for cytotoxicity. Many genetic risk factors exist. Parkinson's is thought to be rarely purely genetic, as familiar Parkinson's is uncommon. Environmental risk factors include exposure to pesticides and chlorinated solvents. Tobacco usage may actually be protective against Parkinson's. Exercise, caffeine usage, and non-steroidal anti-inflammatory drug usage, such as ibuprofen, are also negatively correlated with Parkinson's. No cure exists for Parkinson's. Treatment consists of managing symptoms and slowing progression. Medication, exercise, and physical therapy are the first-line treatments. Surgery may be used in patients who are unresponsive to or intolerant of medications. Most commonly used medication is levodopa, which is a dopamine precursor. Dopamine agonists are less effective, but have fewer complications, and they are often used when levodopa needs to be reduced due to complications. Dopa decarboxylase inhibitors are often administered with levodopa, which decrease metabolism of levodopa to dopamine outside of the brain, which reduces its peripheral side effects and increases the availability in the brain. And dopa decarboxylase inhibitors are even available within the same pill of levodopa. Monoamine oxidase B inhibitors decrease degradation of dopamine in the brain. They may be used on their own or with levodopa, and they're often used as monotherapy during early stages. Exercise of all kinds can maintain or improve mobility, strength, flexibility, and quality of life that may otherwise be lost due to sedentary behaviors caused by Parkinson's. Lee Silverman voice treatment specifically helps speech disorders associated with Parkinson's and focuses on increasing speech volume, while other treatments can be used to help with speech intelligibility. Gait training can provide long-term increases in walking speed for Parkinson's patients. That training is performed by walking on a treadmill while the patient's weight is supported by an overhead harness. Tai Chi has been studied for improving walking and balance. One study found no improvement, another found improved balance, but not improved forward walking. Surgery was very common before the discovery of levodopa, after which its popularity has gone down, though somewhat returned recently due to improvements in techniques. Neuroablative lesion surgery uses heat or cold to carefully destroy brain tissue, forming lesions in the thalamus to treat tremors, or in the globus pallidus to help with rigidity. It is now largely replaced by deep brain stimulation. Deep brain stimulation is the implantation of electrodes which can be used to stimulate the thalamus, globus pallidus, or subthalamic nuclei. It's highly effective at treating tremors, and is favored due to its reversibility. Here are the sources for my presentation, continuing on the next two slides.